What's the similarity between dizzy patients and doctors? They both don't like dizziness. When I teach others about vertigo, one of the harder concepts for learners seems to be the head impulse test, and I know that it can be confusing. But by going into the head impulse test in detail and showing multiple real patient abnormal head impulse tests, I hope I can teach you how to do it better and how to interpret it correctly. What does an abnormal head impulse test look like? This video is by me, Peter Johns, an emergency physician practicing in Ottawa, Canada. Let's have a look at this. What did we just see there? Let's watch it again. In those 2 seconds, you just saw part of a powerful physical examination finding that can allow you to safely send home a patient with ongoing vertigo and nystagmus. That's right, that was an abnormal head impulse test. By knowing when and how to perform and interpret a head impulse test, you can reliably diagnose vestibular neuritis and so rule out a cerebellar stroke presenting with vertigo and nystagmus. So what is a head impulse test and why is it important? Well, it's the most important part of the HINTS exam. The 3 components of the HINTS exam are head impulse test, the type of nystagmus seen, and the test of skew. In this video, I'll be focusing on the head impulse test. There's also HINTS Plus testing, which incorporates a 4th bedside test, the bedside test of hearing, in order to pick up the occasional ICA stroke. If you'd like to hear more about the HINTS Plus exam, there's a link on the screen for a video all about that. So it's important that you understand what HINTS is all about. The HINTS exam shouldn't be used on every dizzy patient. It should only be used on patients who have what is called the acute vestibular syndrome. Acute vestibular syndrome is important because that's where cerebellar strokes that are presenting with vertigo are found. So if you have acute vestibular syndrome, you have to have continuous vertigo lasting hours or days. It's not just a few seconds or minutes or an hour or two. Patients with acute vestibular syndrome feel worse when they move their head. But of course, all causes of vertigo get worse when you move your head. This is in contrast to conditions such as BPPV, where their dizziness is either completely or almost completely gone when they keep still, but when they get out of bed or lie down in bed or roll over in bed, their vertigo goes from 0 to 60 miles an hour in a couple of seconds, and in 30 seconds or so, it's down to almost 0 again. Sorry for the car analogy, but I'm a bit of a car guy. So to extend the analogy, I would say that patients with acute vestibular syndrome have a baseline vertigo of, say, 40 miles an hour, and when they move their head, it goes to 60 for a short time, and then returns to 40 again. And of course, they also have nausea or vomiting and difficulty walking. Most importantly, they have to have spontaneous or gaze-evoked nystagmus. We'll see what that looks like in a minute. Most patients with acute vestibular syndrome seen in family doctors' offices or emergency departments will turn out to have vestibular neuritis. We can use HINTS or HINTS Plus to send these patients home. Some will have cerebellar strokes with additional findings suggestive of stroke, such as unable to walk, diplopia, dysarthria, dysmetria, focal paresthesias or weakness, spontaneous vertical nystagmus, or new, sustained, significant headache or neck pain. Fewer yet will have cerebellar strokes without other posterior circulation stroke symptoms. We can use HINTS to prevent us from sending these patients home. And rarer still are cases of MS presenting as isolated vertigo or first-time Meniere's disease and various other rare causes of acute vestibular syndrome. I've already said that the head impulse test is a powerful physical examination technique and the most valuable part of the HINTS exam. Why is that? It's because almost all patients with vestibular neuritis have an abnormal head impulse test, and almost all patients with a stroke have a normal head impulse test. I used almost because if it were everyone, we'd only need one test in acute vestibular syndrome, and instead we need other components to make it more sensitive to pick up stroke. It's counterintuitive that a normal finding is more worrisome than an abnormal finding. A lot of people get hung up on this one, so make sure you understand. In acute vestibular syndrome, an abnormal head impulse test almost always means vestibular neuritis, and a normal head impulse test means you are worried about a stroke. So how does the head impulse test and the HINTS exam help us? Can it help us get over our deep-seated fear of missing a cerebellar stroke? I certainly think that seeing a clearly abnormal head impulse test, as well as Peripheral results on the other components of the HINTS or HINTS Plus testing should give us the confidence to definitively diagnose vestibular neuritis and therefore rule out a stroke. This is assuming that they don't have any of the other posterior circulation signs or symptoms I mentioned earlier. Okay, I did say that I'd show you 10 abnormal head impulse tests, but we're almost here at the parade of vestibular neuritis. First, I want you to look at the nystagmus seen in this patient whose abnormal head impulse test I showed you right at the beginning of this video. Looking for the type of nystagmus seen is actually the first step and one of the 3 components of the HINTS exam. What's the direction of the fast component of the nystagmus? Is it vertical or horizontal? Is there a rotatory component to it? Does the direction of the nystagmus change when the patient is asked to gaze in the other direction? So when I have the patient look to the left, you might notice a couple of very small beats to the right. When he looks to the right, there's a very definite nystagmus which is beating to the right, and it might have a slight rotatory component to it as well. Importantly, the nystagmus doesn't change direction depending on the direction the patient is gazing. This is called unidirectional nystagmus, also called by other names such as fixed direction nystagmus. This pattern of nystagmus is a HINTS peripheral result and entirely consistent with vestibular neuritis, but we have to perform the other 2 components of the HINTS exam to be more definite. I don't actually have a test of skew in this patient, but here's another one that showed the same finding. I move my hand to cover one eye and then the other. I don't move it too fast, and I'm careful not to touch the patient's face or nose, which might make them blink. I look for any vertical or diagonal movement of the eyes when they are uncovered. Purely horizontal movement doesn't count as abnormal test of skew, only vertical or diagonal. And in this patient, there is none. So the second component of the HINTS exam is again a HINTS peripheral result. Now back to our original patient who, by the way, had a negative test of skew. Remember, his nystagmus was beating to the right. So which is the affected ear? It's different than in BPPV, where the rotatory and vertical upward nystagmus beats towards the affected ear, which is the downward ear during the Dix-Hallpike test. In vestibular neuritis, the nystagmus beats away from the affected ear. Emergency physicians might have an excuse to think otherwise, as Rosen's textbook had this wrong for multiple editions, but it's been corrected now. Now, which side will be abnormal when we perform the head impulse test? It's abnormal when you turn the head rapidly towards the affected ear. So in our gentleman, his abnormal test would be when we turn his head rapidly towards the left ear. Let's see if that's what happens. I'm going to spend a bit of time explaining what we're seeing and what it means. So I hope what you're seeing is that when his head is turned rapidly to the left side, there's an abnormal movement of his eye back to the midline, which is bigger than his spontaneous nystagmus. That is the abnormal head impulse test, because vestibular neuritis has caused him to have an abnormal vestibulo-ocular reflex on that side. And when I turn his head to the right, his eyes stay on target because he has a normal head impulse test on that side. But then what is the vestibulo-ocular reflex? You may not be aware that you even have one, but yes you do. It's one of the essential features of the vestibular system. It maintains your eye's fixation on a target when your head is moving. Is that important? Well, if you didn't have the vestibulo-ocular reflex, when running, your vision would look something like this. Pretty hard to function in the world with vision that looked like that. Now, here's a guy running with a very sophisticated Steadicam, and your vision probably looks a little more like that when you're running than in the first video. So the vestibulo-ocular reflex is like your brain's own image stabilization software. It's constantly adjusting for your head movements by moving your eyes up and down and back and forth when you're moving your head, both when you're still and just your head is moving, and also when you're walking or running or doing anything else. So imagine if I took a GoPro camera, put it on a stick, then put that stick in my mouth so it was focused on my eyes. Then I ran around my yard filming my eye movements. My eyes would be moving rapidly, adjusting to the changes in my head movement, and it would look like I had nystagmus. Now, would you like to see that video? You would? Well, I didn't run around my yard, but someone let their dog do it. And sure enough, it looks like he has nystagmus, when really all he has is a very good vestibular-ocular reflex. So what are we seeing in an abnormal head impulse test? In patients with vestibular neuritis, instead of the eye staying on target, the examiner's nose or the camera, When the head is moved very quickly towards the affected ear, this movement overwhelms the defective vestibulo-ocular reflex and the eyes move with the head. The brain then senses the momentary loss of fixation and says, "Whoops, I'm supposed to be looking at the nose," and adjusts by making the eyes refixate on your nose, and a catch-up saccade is created. And when we see this, we say to ourselves, if the other components of the HINTS exam had peripheral results and there's no additional findings suggestive of a central cause, we say this patient with ongoing continuous vertigo and spontaneous nystagmus definitely has vestibular neuritis and is not having a stroke. Again, note that the catch-up saccade is in the same direction as the spontaneous nystagmus, but of bigger amplitude. The head impulse test is a learned technique and requires the right technique and a bit of practice. My last few head impulse tests were better than the first few I did. In fact, I'll show you some of my earlier ones that could have been better. If you've never done the head impulse test before, it's a good idea to have someone who is more familiar with the technique to watch you do it. This is the same as learning other physical exam techniques and procedures, such as examining for rebound or reducing a shoulder dislocation. I hope you had someone watch you do your first one. Here is how you do it. Have the patient look at your nose or at a camera held by an assistant. Of course, always ask for consent to video the patient. Videoing the head impulse test allows you to review the findings again and again and can increase your certainty of what you saw. I find filming it at normal speed more useful than it slowed down. Plus, it trains your eyes to pick up the fast catch-up saccade even when you aren't recording it. Hold the skull, not the jaw, firmly. An examiner can't injure a normal skull by holding it firmly, so don't be shy. If you don't sense the patient's skull under their scalp, you probably aren't holding it firmly enough. Start with a few slow movements to relax the patient's neck muscles, so when you move their head quickly, you won't cause any muscle strain or injury. Then start to perform the quick movements about 20 degrees from lateral to midline. Moving from lateral to midline is very unlikely to cause patient discomfort or injury. I don't have to tell you that an exuberant beginner moving from midline to lateral, if they overdid it, well, you can see how that could be a problem. It's pretty unusual that something bad would happen, but you wouldn't want someone to go from midline to lateral rather than lateral to midline and have something bad happen and then have to say, "I told you so."
Told you so.
When you perform the head impulse test, activate your whole upper limb, not just your wrists. Get your biceps and pecs in there. You can move a patient's relaxed head from 20 degrees off center back to midline at high speed and you're not going to hurt them. If you move their head too slowly, you might not see the catch-up saccade very well, and we're all about seeing the catch-up saccade. In a sort of random fashion, alternate the fast movement going from left 20 degrees off center to midline and then right 20 degrees off center to midline. David Newman Toker likes to say it should be done like atrial fib, irregularly irregular. If the patient can anticipate when the fast movement is going to occur, the catch-up saccade may occur just as you start moving the head and you may not see it. This becomes what is called a covert saccade. So keep them guessing about when you're going to turn the head quickly to midline. Okay, on to the next patient with ongoing constant vertigo and nystagmus. Describe whether his nystagmus is horizontal or vertical and whether there's any rotary component as well. In people with darker irises, look at the small vessels to see if there's any rotary component to the nystagmus. And finally, decide whether it's unidirectional nystagmus, a HINTS peripheral result, or bidirectional nystagmus, where the direction of the nystagmus changes when he looks left or right. Bidirectional nystagmus is a HINTS central result. When he's looking straight ahead, he has some spontaneous nystagmus, that is, nystagmus seen in primary gaze, and it's beating a little to his right. When he looks to the right, it becomes more intense, and it's easy to see the rather prominent rotary component towards the right ear as well. When he's asked to look to the left, the nystagmus becomes less, but it still beats towards the right, so this is unidirectional nystagmus, so a HINTS peripheral result on this component of the HINTS exam. All this so far is very compatible with vestibular neuritis. So again, which side will you see an abnormal head impulse test on? Well, the nystagmus is to the right, therefore the affected ear is the left ear, and the abnormal head impulse test will be seen when you turn his head towards his affected ear, which is his left ear. Now, you don't have to see an abnormal catch-up saccade on each turn of the head to the left. As long as you see at least one clear abnormal one, then it's an abnormal head impulse test. The first and third turns to the left were clearly abnormal. I'm going to spend a little time giving emphasis to the speed in which the rapid movement of the head impulse test should be done. Say the word quickly at normal speed. Quickly. If the rapid movement of your head impulse test takes as long as it takes to say the word quickly at normal speed, then it's not quick enough, and it'll be difficult to see the catch-up saccade if it's there. Now say the word quickly very quickly. Quickly. Let's look at the last video again and see if the rapid head movement is performed quickly like quickly or quickly like quickly. I'd say that was pretty quickly, and it's pretty easy to see the catch-up saccade when it's done this way. Now look at the same patient having his head impulse test performed by a less experienced examiner. The rapid head movement is being performed slower, more at the speed of quickly than quickly. So it's much harder to see the catch-up saccade that was easy to see when it was performed quickly. Quickly. Not fast enough. One more time. Quickly. Was there a catch-up saccade there? Hard to tell. So much easier when it's performed quickly. Here is another of my colleagues doing their first head impulse test, holding the mandible, which is somewhat mobile, so it's hard to make a clear endpoint with the head turning, and also turning the head from midline to lateral, which as we saw, isn't for beginners. I think you can see an abnormal head impulse test on the last turn to the right, but it's not easy to see. Here's the most recent head impulse test I've done, about 6 weeks ago. You can see she has spontaneous nystagmus to the right, so her head impulse test will be abnormal when the head is turned to the left. Notice the difference in hand position compared to the last video, and the speed of the head turn compared to the video before that. Now describe this man's nystagmus. He has spontaneous horizontal nystagmus with a rotatory component beating to the left, which increases in intensity when he looks to the left. When he looks to the right, it lessens but is still beating to the left. So unidirectional horizontal rotatory nystagmus beating to the left. If you've been paying attention, you'll know which side the head impulse test will be abnormal on. And it'll be when his head is turned to the right. There's an abnormal catch-up saccade there. This is going to be a little bit of nystagmus, but not a catch-up saccade. And here again, a catch-up saccade with his head turned to the right. Bang. What about this guy's head impulse test? To the left is normal, to the right, a very clear catch-up saccade. He actually told me when I turn my head to the right, I have to wait for my eyes to catch up. This lady had all kinds of vertigo for several days and was unable to stand unaided, and she had nystagmus, and her head impulse test is normal on both sides. So that's good, isn't it? Nope. If a patient with vertigo and nystagmus for hours or days has a normal head impulse test, it can't be vestibular neuritis, so it must be a central cause, likely a cerebellar stroke syndrome, which is what she had. If you've been paying attention, by now you should be able to describe the nystagmus in this man. So I'll let you watch this video of his nystagmus, and then I'll give you some time to describe it and decide which is the affected ear and which side you'll see the abnormal head impulse test if he has vestibular neuritis. Okay, watch carefully. Very good. When looking straight ahead, he has spontaneous rotatory horizontal nystagmus beating to the right, which increases when he looks to the right. When he looks to the left, it becomes less, but still beats to the right. So he has unidirectional nystagmus, which is a Hintz peripheral result. And the affected ear? Yes, it's a left ear. And if he has vestibular neuritis, his abnormal head impulse test will be seen when we turn his head quickly towards which side? Yes, again, when we turn his head to the left. Again, another somewhat inexperienced examiner, so room for improvement. Should have had the hands higher off the mandible and didn't need to do that big of a head turn, and the rapid head movement could have been done a little more quickly. But in any case, this man has mad catch-up saccades. You can't miss this one, I don't think, especially the last two head thrusts. This is one of my early head impulse tests. You can see that my rapid head turns were too big, much more than 20 degrees. Now, as you've seen, I've adjusted my technique, but a big catch-up saccade when her head is turned to the left. Here's another early one. I start with my hands on his mandible, and then I correct myself by moving up to the skull. Again, I didn't need to turn his head quite that much, but I do get a ginormous abnormal head impulse test when I turn his head the last time to the right, which is right there. Big one. This gentleman had short episodes of vertigo lasting about 20 seconds when he rolled over in bed or got out of bed or lay down in bed. When he stayed still, his vertigo pretty much went completely away. He had no features to suggest a central cause, and here is his left ear Dix-Hallpike test. After a couple of seconds of latency, he developed a crescendo-decrescendo nystagmus lasting about 20 seconds, which was rotatory towards his downward left ear and had a vertical component upwards also. So what do you think his head impulse test showed? Well, guess what? I didn't do one, because he has the classic story and findings for posterior canal BPPV and should not have the HINTS exam or head impulse test performed on him. Why? Because, as we said earlier, the head impulse test is abnormal in vestibular neuritis. BPPV is not a vestibular nerve problem. It's a, I've got a stray otoconia in my posterior canal problem. The head impulse test is normal in patients with BPPV as well as all normal people. So if you decide to incorrectly perform the HINTS exam on a patient with BPPV just to be thorough, you'll find that they have a normal head impulse test, which could erroneously lead you to thinking that they're maybe having a possible stroke or TIA, which can lead to unwarranted diagnostic imaging or antiplatelet therapy and referral to neurology, when in fact all they needed was an Epley maneuver to cure them, which is what we did with this man. Here's the last one, and again one where I turn the head a little bit more than necessary. And this is the most difficult catch-up saccade to see by far. He didn't come to the hospital in the first few days of his illness because he felt too dizzy to leave his house. So his vestibular neuritis was starting to settle down a bit, and this led to seeing smaller nystagmus and smaller catch-up saccades. Definitely gaze-evoked nystagmus, which is horizontal rotatory beating to the right when looking to the right. Can't really see it when he looks to the left, which is typical of vestibular neuritis after a few days. On head impulse test is a small catch-up saccade on every rapid head turn to the left. You might have to look at this several times before you see it, but it's there. Okay, to sum it all up, only perform the HINTS exam, and therefore the head impulse test, in patients with acute vestibular syndrome, where the patient has ongoing constant significant vertigo for hours or days and they have nystagmus. Go ahead and practice it. If you don't practice it, you won't get any better. Taking a video of the head impulse test can help you review what you are seeing and make you more confident in your diagnosis. Send home the patients who screen negative for central features and have a clearly HINTS peripheral result. For more information on how to screen your patients for central features and to figure out which bedside testing to perform, watch my Big 3 of Vertigo video. I also have videos on HINTS and HINTS Plus. The links are on your screen. Thanks for watching.